Hi, welcome to part 2 of Nora's craniosynostosis story. In this video, you'll see Nora go through a series of evaluations that highlight the common challenges craniosynostosis patients face. In 2019, Dr. Singh told us she wanted to schedule a CT scan so that we could get baseline imaging to monitor Nora's growth and development over time. Multi-suture craniosynostosis is extremely rare. So in December, when they called us with the results, we found out that Nora might need a second surgery for left lambdoid craniosynostosis. The doctors told us they were going to schedule a whole series of evaluations to determine the correct path forward. They scheduled a feeding evaluation, a speech evaluation, a psychiatric evaluation, genetic testing, a swallow study. We thought if they're going to be doing all of this, it was probably a good idea for us to start documenting Nora's journey. So our story picks up in March of 2020 when Nora had a very busy day, as you're about to see. How you feeling, Nora? Happy? Yeah. We're gonna go meet with the craniofacial team to talk about her potential surgery needs coming up. We're gonna meet with a speech therapist, and then we're gonna meet with the neurologist and the craniofacial surgeon, and then we have a meeting with a child psychologist to evaluate whatever they want to evaluate. We don't really know what we're in for.
What's this?
Duck.
And what does he say?
Quack.
Good job. Oops. Who's this?
It's a spider. Like Rebel doesn't like spiders.
No, I don't like spiders. What is he on?
A web.
Uh-huh. Good job. What's this?
It's a drum.
Okay, does one of these look fun? We have a troll doll or dinosaurs.
Dinosaur.
All right, good choice. There you go. I'm really pleased with her speech, articulation, and her language functioning. We continue to follow language really closely in kids with a diagnosis of craniosynostosis because they have a risk factor of delays or difficulty with language skills.
Okay.
So let's imagine you're in a situation, you prepare her for it, you're in the store, she doesn't want to leave, she's starting to, unravel a little bit. How do you guys handle that?
Bribery.
Yeah.
I say if you calm down and
We'll go
come
home
to the
and
car with me.
have a treat.
Give you
Or...
a treat, yeah.
Does she calm down?
Not always.
Not always. but
Given all the information we're getting and we're in the process of getting, this is going to help us make recommendation. I'm just looking at facial growth compared to when I saw her back a few months. And I feel like she's got a little bit more curvature to the face.
Okay.
And I know, having had kids just with unicoronal synostosis, that this is not the
That
source of it.
doesn't-
A
okay.
little bit back here, but this, if you go from top to chin point, and you notice this, what we call the scoliosis of the face, that's related to the left lambdoid synostosis.
Okay.
The bone, I'm just going to repeat some of the stuff since you're recording it.
Okay.
The bone is thinner on this side compared to the unaffected side.
Okay.
And I feel that that's because we're constrained front to back here.
Right.
And the brain
So
is
the
trying
brain
to grow.
Right, okay.
And this is the area also Dr. Bristol showed you on the MRI where it's very tight in this area where the bone has not grown. It looks
Right.
pushed in, and so the brain and the brainstem is adjusted accordingly there.
Yes, okay.
We're worried primarily about the functional aspects. but we don't ignore the form, and we don't ignore the facial growth, right? Because that's what we're here to monitor. And in 3 years, when she's 6, 7, 8, and she says, why is my face like this? And what can we do to fix it? The goal is to prevent that abnormal growth, because it's a lot harder to fix it than it is to prevent it. And the earlier you reset the growth pattern, the better long term. But it's not, I don't want you to feel like it's emergent.
But we need to, and we need to make sure we know the right plan of action. Okay.
She's very sweet.
Yeah, she's a sweetheart.
Nora, do you have any questions for us?
I think so.
Yeah, you want to ask us?
I really want to play.
You really like to play.
Yeah. All right. Well, thank you guys for coming in. I know it's a lot of appointments and everything, but we just want to make sure that we stay on top of, you know.
How have things been with Nora in terms of her eating and swallowing?
Still,
Still
come and go. You know, she'll eat really well for like a week, and then she'll like not eat for a day, and then it's kind of have to build back up momentum. But in general, she's been improving, and like you can tell she's gaining weight, and she just seems to be growing.
And then, is she snore at night?
I haven't noticed any.
No.
Okay.
Yeah, I do.
So are you able to see Nora's CT scan?
Yeah.
Okay, so I'm going to rotate this. So this is the frontal region that was operated on. So this is a full thickness bone defect, as is this area. Are you able to see my arrow scrolling on it?
Yes.
Okay, and then this obviously is not, it shouldn't be there, but that's compensatory growth where her brain's trying to grow, because as we scroll around to the side, this is what we discovered when we imaged her, because we didn't have any prior imaging from California, was that this seam is closed.
Right.
Kids who go untreated, and when they go into their, middle school to high school years, the face has a pretty significant curve to it that then cannot be corrected. And so a little bit of Nora's asymmetry in the front is just related to her craniosynostosis. But I would say when I look at Nora and I look at Nora's CT scan, about 75 to 80% of her facial asymmetry is actually related to the back suture being closed. Because one, that's never been operated on, and two, we didn't know about it until we got the imaging.
I think that her brain's going to need more space in that upper back part. And I think we need to open up the space that goes down towards the neck. That's what we call the foramen magnum, or that's the very bottom of the skull, so that the tissue there isn't pushing on her brainstem, because that can then give you problems with balance and coordination and arm and leg strength and control over time.
It does not need to be inherited from parents. It can be a spontaneous mutation. There are kids who have, at the time we operate on them, have one synostosis. And then they go on to get another one. So we here at PCH have had children where we get the CT scan, we see the one synostosis, we operate on it, and we follow our kids out until they're skeletally grown, and we notice asymmetry developing. We get another CT scan, and they've got another suture that's closed. Our recommendation is operating on the back of the head. We would use the same incision. Dr. Bristol's role would be removing this bone safely and decompressing the area that's tight, and she can talk to you a little bit more about what that entails. My job would be to take this bone, rearrange it so that instead of having this compression and tightness here, we have a fullness on both sides that are symmetric and allow her brain to grow.
And I'll order one more thing, which we can do on the same day of surgery, which is to look at where the veins on the inside of her head run. Because sometimes people who have an anomalous lambdoid suture, their veins will either only be on one side, or sometimes they run superficial. So, but that's just right before surgery. Okay. So that'll be all kind of lumped in the same day.
Gotcha. Now, would we, like, after surgery or at some point, would we get another MRI to have kind of a baseline to watch over the future?
Yeah.
Because she's really
Yep.
excited to go in the spaceship again.
I bet.
Well, it was great to connect with you all, and we look forward to seeing you all in person.
All right, thank you. We look
All
forward
right,
to
bye,
seeing you.
Nora.
Bye, Nora.
Bye. Oh, and she's...
Oh, we're gonna hide from the doctors again?
All right, we'll see you soon.
Bye. Take care, you guys.
Bye.